Dear Pure Urology Facebook viewers, good evening one and all. Recently we have started semi-live surgery program in Pure Urology. This will be useful for the juniors to learn these surgical techniques from the different faculty. I requested already some of the eminent faculty across the world to record totally unedited video of small steps. Sometimes it may continue as surgery if it is important, or else we can cut it. But important point is you need not attend the live surgery program. It may not be possible always. Many of the workshops are happening, but some people may not reach to these workshops. So technology has changed. With a simple cell phone, again today we have recorded this with simple cell phone. I hope this type of surgical techniques will be useful. Only request is, if you are a urologist, inform other colleagues who are in need of these type of programs and encourage them to join Pure Urology Facebook group. Today I am showing prone PCNL. Do not ask me that why you are showing prone PCNL, because I have 15 years of experience with prone PCNL and last 3 years of experience with supine PCNL. I was thinking of Supra Costal puncture demonstration. The case has come few days back. I was recording with this purpose. The important point I have already mentioned in the message that supracostal puncture, the lateral calyx puncture, the RGP, the laser, the initial dilatation to small size, then confirmation, all these points are discussed in the present video. So I will directly go to the video. If any doubts are there, I will be observing the chat box. We can discuss freely, liberally with whatever the limited knowledge I have. At the same time, seniors can also give suggestions that any better can be done in this surgery, because one person, one technique, one surgery can never be 100%. So with this, without wasting time, I will go to the direct live to the theatre. The sound will. Today we are demonstrating supracostal puncture prone PCNL, and it will be done by trainee. How the trainee will get and how the mentor will interact, and then ultimately lead to the good outcome of the patient. Any patient which is there, first you have to see whether there is colon or viscera here. So there is no colon viscera, even though it is supracostal, large stone which is medial. See, this is lateral, this is medial. Small 1 millimeter also you have to interpret. If you see here, it looks medial. Everybody thinks that the puncture directly on the stone. It is not correct. RGP is important. Without RGP, don't make any impression like case is easy, I can puncture the stone, I can go directly. No. RGP, then assess lateral puncture, safer superficial lateral puncture is the aim up to the stone. If you directly go to the stone with the calycial puncture, fine. If you go through the another calyx, then you have to think, do the small dilatation and then go inside. That let us see. In prone PCNL, we will see this part more. The kidney will be somewhere here, there is no doubt. If you have ultrasound, there is a luxury. But we don't want to show ultrasound today. We wanted to show CR. First important point in prone PCNL, this should be horizontal. It should not be tilted like in supine PCNL. This should be horizontal. This should be horizontal edge of the table. Number 1 point. Number 2 point, reading the RGP. Is it stone? No, it is stone. Whenever there is stone, you should see it is a good radio opaque shadow. If it is seen, you can hit the stone. It is good. Before injecting the RGP, see the stone again and again in relation with the rib. This is the 12th rib, this is the 11th rib. Now one time respiration, movement you have to observe. Start the respiration, Siam continue you press, movement you have, video mode, you have to know video mode which is, continuous you play.
Continuous, yeah.
See, it is moving. You can see the rib here, you can see the rib here. It is relatively, with rib it is moving.
Yes, sir.
With rib it is moving. Bus. Isn't it? Without rib it is moving. But little 1 to 2 centimeter. So it's at the level of the 11th rib. On the 11th rib it is falling. On the 12th rib above it is there. That means it will be supracostal puncture. Tentatively. Now we inject contrast. Now we inject the contrast. You inject the contrast slowly. How much? Thick contrast or dilute contrast? Dilute contrast first. Thick you can do later on. You understand? Now dilute. These are all ABCD of prone PCNL. Inject slowly. Slowly. See. Now what's happening? Inject. See, this is the lower system. This is the upper system. And this is the medial calyx. And wait. Now at this level, you should not inject more. You got little bit of information, enough. You got a lateral nice calyx. From here to here you can go. Again one press, proper press, bas. See, now this is the picture. This is correct. You keep it here. Now respiration stop. You put it here on it. Why are you not putting? Go medial. Like that. Now you mark where will you puncture now in trial. Now you see it is moving better. Puncture now. Puncture, yes, it is moving. Do you think it is puncture has happened? Don't go beyond that calyx. Now how will you go? 30 degree towards you. Shift 30 degree towards you. Shift Siam. What is happening? Create some space. And Terumo also you keep respiration more down. Yeah. Siam. Respiration down only we punctured. Siam. Give me the Terumo guide wire. Because this is stiff, it may not go. Wait. Now Terumo guide wire you are using. Now see slowly blood is coming because it's moving. Siam. Respiration. Because with respiration it might have gone. So it is going only into the calyx. Okay, stop there. Then you go to that calyx and see what will happen. So you and I could not do any difference. Now you do dilatation. What will you do? Single step dilatation, microperk you do. Or up to 15 French, 2 dilators. What is the dilator you use? This is the one dilator. This is the second dilator. This is the one dilator. This is the second dilator. After that you will use this. These 3 dilators if you use, microperk you can go by the side. Decide whether stone can go up, you can go up to the stone or not from this calyx. Otherwise no use. So now you take this dilator. You pass this dilator. Meanwhile you cut the the skin properly. Only these 2 you keep here. Everything record up you cut, yes, liberally you cut, no problem. Cut deep a little bit, bas. Now you go deep and maintain the same direction. Every time it is deep inspiration it was coming. Go. See I'm deep inspiration, stop. Because you punctured in deep inspiration. See, turn little bit like this, body language. Yes. Now go slowly, rotation movement, not forward movement. Direction is vertically. Check up and down. Yes. Up and down, some kink is happening. Up and down or like that. Yes. No, some kink is happening again. That is rectus sheath. That you have to bypass. Be careful. No. It is kinking. In that case, what is the trick? You are very superficial. See, your puncture was like this. You are trying to do like this. That is a mistake. Hold it, Siam, and keep withdrawing. See, keep withdrawing. Rotation, see, you observe. You don't know the angle, it only has to receive. Now, this is the one, this is the depth. and again this is one thing, this is one thing. It is causing if you do oblique tract, this can happen. See, so in that case what you have to do? Withdraw. See what happened here. See, withdraw. See what happened. It is destroyed. This is destroyed. That's why it is not moving. So what you have to do? It will not go. It will not go. Bigger one is there. Give the bigger one. It will not go. See what happened here. It is destroyed. It is very dangerous now, because you cannot remove the guide wire. We will see bigger one whether it goes or not. Because you have to travel this irregularity.
Yes, sir.
You got the point?
Yes, sir.
This is unfortunate that thermo guide wires are very, very. See, if it goes, I am happy. Yeah, it has gone. Now I will do the dilatation. See, see, this dilatation is okay. It's not going. Respiration. See, I am changing the direction completely and it is not going. It is coming out. So what probably acute angulation here might have. I will try slowly. It's not going. Something is not perforating. You see, this direction I am not able to get it. See, here only this direction is changing. Probably you might have gone like this, like this, like this, like this, like this, like this. See what originally your direction was low. I was thinking like this. So you change and continuously do. Wait. I wanted to remove and check again. Don't be in a hurry. Don't worry. Guide wire will not. See. Properly guide wire has not come. See. Supervision. It was like this. You got the point. After certain direction, it was like this somehow. Okay. See, it was like this somehow. See. So puncture should be a straight puncture. Now give me the. Now single step dilatation. This is advantage. Every time you need not negotiate those things. Now you see. So this you got the point. You should not lose such a precious puncture, na? See, now hold it. See, observe. Hold it and rotate. See, inject contrast. See, what are you showing? Now inject contrast and saline. Now guide wire don't lose. You take what now? Microper. Now you go and travel inside. How it will be? Microper give 7.5 French. Why 7.5 French you are taking here? Because you have to remove this guide wire if you want to put the 12. If it is 7.5 with water, you need not remove. Once you check, after that you do whatever you want. You put up to 30 French also, no problem. From below and above saline. Water please. See. Now you go inside, you see and wait for see. Immediately what you will see? The blood. Take out the CM. Immediately what will you see? Blood. You are in the calyx. Okay. Once you are in the calyx, you can remove this guide wire. Remove this guide wire. It is no meaning. Top lights off. Record that also. You know how to record that. Now you rotate and go to the calyx. Where is the calyx? Now it is searching the calyx is the flux. Water saline first from below. Saline. So why you are flushing saline from below? To clear the. Now we have to find out the track. How to find out the track? Top lights off a little bit. Where is the calyx? We don't know. Whether down or up, we don't know. We have to find out the mouth of the. Suck this. Should have patience. We are in the calyx. There is no problem. Suck. नहीं आ रहे चलो ठीक है you are in the calyx now see you are in the calyx is there any way we can go here no it is a direction which has changed. Okay, now here come back, no problem. This is the periphery of the calyx. Is it the calyx or not? See, now I am going up, I am going up, I am going up means it is more. I am turning here. This is the calyx, na 100%. Huh? Yeah, now more posterior. Every angle you see. Better. Okay, that clot is not coming out. Okay, now I am coming down. See, my foot has changed here. Now I will go. See here, lower part. See, I am able to see something here, isn't it? Something here. First I want to suck it out. Yeah, suck it out. This only can suck. Why? Suck. If the guide wire goes into the ureter, it is easy. See, can you see the stone now? Can you see the stone? So like this, you have to do the surgery. Very safe. Now what you have to do? You turn this. See how I am turning. I am turning slowly. See. Okay. This infundibulum is narrow. So you should not tear the infundibulum. Now what you have to do? You take a large nephroscope. You take the laser. Beautifully paint it. Okay, without damaging the infundibulum. How much time it took? Entire thing, this process, it took only 5 minutes. But patience is important. One more thing here. You try to see lateral calyceal puncture, never a problem in the. See, you try to go above this stone and try to see all around whether you have the space or not. Once you have space, it is easy for you to manage because it's a large stone. Because it's a medial calyx, you can use the pneumatic lithotripter or large laser fiber. You use a 500 micron laser fiber. You take this scope only, and from below she will be flushing. Nicely you powder it. Thank you. You powder demonstratively. You got the point? Yes, so I helped you in two aspects. One is dilatation. It has gone down like this. After that, up like this. So if you change the needle like that, dilatation becomes difficult. 360 micron fiber. Era నెమ్మది చేస్తాం. మేమంతా ఇక్కడ అడుగుతా ఉంటే ఏమంతా కులుపుతా ఉన్నామేంది? మేము ఇక్కడ రెడీ చేసి పెడతా ఉంటే రెడీ ఉంది. ఇప్పుడు ఏం చేయాలి మేము? సో యూ విల్ డూ నౌ, both of you. Pneumatic lithotripter is also good, but lot of fragments. You have to take the bigger scope. So either bigger scope better, smaller scope better. Bigger scope better. I will change the bigger scope. Record everything live. Record. Hold this, and take it out. And what is this? Too much bent it is. My God. Okay. Large access sheath, does it have any meaning here? No. Risky of puncturing so medially, does it have any meaning? No. See, with little exchange also. Now laser or pneumatic lithotripter? Pneumatic lithotripter, the fragments may go into other calyx, into ureter. So try to use laser. After that, go inside and use laser. Practice with laser, no problem. Pneumatic lithotripter is fast. You want to use small pneumatic you have to give. Use laser. Enjoy with laser. What is there? You have space. You have done RRS, na? So you see, like this you touch. You know this, without touching the infundibulum, Guru. Yes, okay, this is the lateral calyx. Posterior anterior doesn't make any difference because now aram se position yourself. Right. 1 and 10 John. ఇది ఎందుకు వాటర్ ఇట్లా కారుతా ఉంది? ఇది దీన్ని ఇట్లా ఎవరైనా పట్టుకోండి, వాటర్ కారకుండా. రైట్. ఓకే, table height increase. Yeah, slowly. Right. Start fragmentation mode 110. Right. Very good. Stop and start also, no problem. Don't try to do fast. Don't try to do continuous also. Take 15 minutes of time. Nothing will happen. Yes. Yes, this and that you keep recording.
Laser.
Hey, laser fiber. Laser fiber. Here only you stand. Acha, laser energy settings you are showing. Good. Table height increase for him because he is tall person. Table height increase. Yes, very good. This gives lot of confidence. At the same time she is flushing. No fragment will be there. You got the point, Somnath? Yes. Yeah, like that. Next case you come. And today all URSL, RIRS, you do compensation. Like that, you adjust. Good that you have come. I thought you will not come. So by seeing messages, if it's important is there, you should sacrifice the for this thing. Right, very good. Like that you keep on digging the center only, no problem. This stone will not go anywhere, Dipesh. Why? It is in a room. It is not in the pelvis. It is in a calyx. At the end you put contrast in this and see. You people are understanding? See there, show there how it is on the calyx, separate calyx. That he is in that calyx now. Medial and anterior. You should not puncture that as a junior. There will be communication between the lateral and medial because it's a compound calyx. Very rare that if you don't have communication, this puncture and dilatation becomes waste. You got the point? You take time, aram se. Beautifully it should look like at the end. It takes only 10 minutes. Don't unnecessarily worry. Don't think that rheumatic lithotripsy will do extraordinary job. Yeah, like that. Freezer is there for the amplus sheet. You keep on doing. Go up to bend. You also bend your hand. Yes, like that. Beautiful. Yeah, later on it will drop. See, dropping. That is the beauty of the. You need not do anything. It will drop. Don't worry. It will not go anywhere. Go down and act normally. Be comfortable. You can scope whether I don't know whether goes inside or not. Later on we will see. This powder cannot go anywhere. Why? From below she is flushing. You are making micro powder. See, beautiful. Nearly 20% of the stone is over. You get space and it will become much easier. See, hard stone. Same RIRS you will do, but water logistics are better. So you cannot say that I will do RIRS. If the ureter is very much dilated, if the RIRS surgeon is very experienced, you can compete with the mini pair. No doubt, like that. Do below only, don't worry, that will fall down later on. Don't worry. Evacuate the floor. Roof will fall down. Come back, let it come out. Come back completely, be happy. Let a vacuum effect come out. Yes, he will suck. See, he is keeping suction at the beginning. Shaw suction sheath, if you keep, it can do very good job. Continuous suction you can do. Yes, go inside. Very good. Right. Top one is there, below one is there. Slowly do it. Don't touch the mucosa. Craft work. This is what surgery is. Craft. Slowly. Yes. Large diverticulum, you imagine that. It's a large diverticulum. You are looking down means is the diverticulum or calyx is anterior or posterior? Anterior. So it's puncturing. This is risky or not? Very risky. So we have gone through lateral. That's why 90% of the times go lateral calyx and do the job in the inferior calyx as well as the superior calyx. Whereas in middle calyx, lateral does not have meaning. Anterior, posterior. There your knowledge. See, it will drop. Don't worry. Keep doing. Don't try to aim the head. Aim the tail only. Otherwise, if you aim the head, you will touch the mucosa. You touch there only. Go inside. Now next step is whether you can go through the infundibulum or not. Rotate the laser fiber so that you can remove that blue one. Yeah, very good. You are dilating nicely. Excellent. 1, 2. Don't push the amplus sheath. Only push the, yes, very good. This is a very important step which I always see. Dilated already. Enough. Do it. Do it. Do it. What is the energy levels? We get tempted to go for high energy now, which is not correct. What will happen if you go high energy? Larger fragments will form. They will not come out so easily. Already see they are obscuring your vision. If they become bigger, you have to use the forceps. Once you start using forceps, pneumatic is better. So it is the patience versus hurriness. What do you say, Ramshna? If you have patience, laser will do miracle and stone free rate will be less. Stone free rate will be more. Now again rotate and see where you are. Like that, press, very good. Once, again, to come out, let the fragments come out. Yeah, now, yeah, very nice, very slow, very good, excellent, slow, don't be too rough. Yeah, it won't dilate in as your mind says. It should have, no, not like that. You should be going close. Your nephroscope should go close. In that case, I am telling you, you can use mini nephroscope and nothing will happen. Ultra mini perk is better, 7.5 French. So rotate the this laser fiber so that rotate. That is the trips. Yes. Now is it seen? Yes, no. These are the simple tips and tricks. You got the point? Yes, any mucosa which is coming, remove it. Now nicely you paint like RIRS. Yes, nicely you paint. Very good. Yeah. Down only, no up. If you remove the floor, the roof will fall. That's all. If the pillars are removed, what will happen to the building? It has to fall. Same thing, if the entire stone below is a pillar is removed, entire roof will fall. Why unnecessarily put strain on the infundibulum? No need. Yes. Now you increase 1.5 joules there. Because take out the laser paper and clean a little bit. You can cut it off also. Scissor. Table height increase. Scissor. This is the way you normally cut it off. Simple. Snip it off. That's all. That's all. Simple snip it off. No need. The high energy efficiency will be there if you snip it off with scissor. Now you go increase the table height full maximum extent so that you will not bend. Okay, right side you have to press. Okay, now move the laser fiber fast. Don't stay at one place. Enough. Don't dilate too much. Enough. Yes. Fast. Laser fiber hit the stone. Nothing will happen. What are you doing? Yes. Come on, start. Yes. Now energy is 1.5 because it's hard stone. I have calculated that it will take little less time if I increase to the 1.5. Only floor. Don't go to the roof. Finish the floor. Yes. Yes. A little above. Center. Yes. There. Continuously keep on moving. No question of laser keeping at one place. Continuously keep on moving. Yes. Now go to how much is the fragmentation mode now? 1.5? 15.1 కాదు 1.5 10 you do it. Frequency does not have any role in the fragmentation. 1.5 10. 1.5. When you say ready, you will do it. 1.5 10. Alright, start.
Ready.
Ready, start. Now observe whether energy bubbles will increase more. Go up also little bit. Yes. Edge. Try to trace the edge. Here also edge. Yes. Then appreciation of the laser when you do at the edge. You come below edge. Yeah, now go to center. Go to center, go to the other edge. Yes, here you have good edge. Other side, yes, 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 yes. Do it, no problem. Let it take time, no worry. But for patient it is one time surgery. But definitely RIRS, this is a large stone burden. This edge again center is taraf left below. See, that is the edge. Then it is destroyed. You are creating edge by the craters. Yes, very good. Now you press inside, make a hole technique. Do same thing. Hole technique 1, next hole 2. No, dig inside. This laser is advantage bas enough. Again dig one more area. Create the edges. Center, if it breaks down, what will happen? You will get space like that. Weaken the stone core. How will you break? Normally one stone 1, 2, 3 times you put and suddenly it will break. What is the advantage of breaking? You will get space for the more edges. Lesser the edges, more time it will take. Like that. Yes, now edges have formed. Can you see now?
Yes, sir.
Yes, you appreciate that?
Yes, sir.
Go to the other edge, free edge. There, edge. Yes. Nothing will happen because there is a lot of space. You have seen contrast filling up that calyx. You wanted to use pneumatic lithotripter. Small pneumatic lithotripter you give.
Stand by.
No, stand by, you keep on doing. Don't waste time. Let us see what pneumatic lithotripter can do. Small pneumatic lithotripter with this thing you give. Small. This is small. Okay. Give me the this thing. This is beautiful, no doubt, but it will take time. Whether the pneumatic lithotripter will do job or not, we will see. Take out. Stand by. Now pneumatic lithotripter here. Please keep it inside. Hold it. Keep it inside. This is a small pneumatic lithotripter which goes into the. See. Now you break it left and right. I will break it. Intermediate you keep it. Intermediate you keep it. Bas. Okay. Okay. Yeah. Flush from below.
Just a flush.
Flush from below. Go inside. Go inside. Up. Okay. Don't. Right. Now fast. Fata maro. Maro. Continue maro. Yes. Below. Yes. That is the correct way. Yeah. Next. Yes. Break. No problem. Break. Continuously break. Use this is a called popcorn. Increase the frequency maximum better say full normal mode better say. No, don't come out. Break like a laser. Okay. Right. Next. Yes. Stop it. And again do it. Stop it. Again do it. Yes. Stop it. Do it. Stop it. Do it. Even here also, if you increase frequency, you will not see the come out. Let the fragment come out. Flush sister. Now you go inside again. Continuously do that. After that, we will do popcorn. Okay. All options open. Right. Go. Large fragment you aim. Very good. Up. Very good. Down. Very good. Again. Very good. Don't force medially because it's anterior. It may perforate the very good. Yes. Don't force more inside. Come back a little bit. Come back and see what's happening. Okay. Go inside. Come out. No problem. Take time. You can't be hurrier than this. This is the maximum hurry. Okay. Nicely. Yes. Break superficially. Don't push. If you push, entire thing will perforate. Touch like a girlfriend, not like wife. Okay. Just like that. It's not like this. You got the point? Superficially touching. It's a stone versus you. Next. Flash from below somebody's sister. No, you are not seeing anything. Use the time to use the forceps. You take out the laser fiber. Forceps, please. Yeah. Take the forceps. Take out the forceps and take out those no, cart only you take out. Water please here. Okay. Carefully open. Yeah. Yeah. Open. Hold it and rotate and come out. Suction. Yeah. Take it out. Enough. Yeah. Where is the pneumatic lithotripsy? Yes. Now you go inside and break any bigger pieces there. You break it. Push with scope. Push with scope first. Push with scope first. Create space. Yes. You break now that piece. That piece. Yes. Final piece. Top piece. Top piece. Yes. 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 Yes, that is the way you create the space. Little less rough, less rough. You are showing overconfidence. That up. Let the probe in. Let the probe come out. Yes. Press it. Yes. Thus. Again, touch the probe. One small bleeder can take out the entire performance. This is a large stone. Okay. Now give it to me.
Yes,
I will show some extra technique because you have to see now
yes, sir.
how you can finish fast. See, holding the scope, see, like this is very important, and aiming, not pushing too much. Okay? See, like this. See, like this. Normally you keep targets like this, like this, like this. Something when you are aiming like a snooker, you will go 1-2 times like this. Okay? See, like this. Meanwhile, water is coming. See, like this snooker. See, can you see the difference? Not instead of blaming blindly, you now how to take out the fragment. You see, you keep this, and keep pushing this. You keep pushing this, and you come out. This is a slightly larger piece. That's why forceps may be required. You don't have any problem here. See, you rotate like this. See, you observe the point. What I am telling, very important. See how big pieces have come. See, whatever the small pieces are there you have made, you go there, you rotate, see, and you turn like this, and get it back without using the forceps. Water from above, below, please. See, bend it down while it is coming out, like in a supine PCNL. Now, pieces, if they are big, they won't come out, like this. See, can you see? If the suction is there, like Shaw suction, it will be much easier. See, now this fragment you target like this. Got the point? Like this. Now again pneumatic lithotripsy because this is a big pieces are there. So I decided that let the see how they are coming. You got the point? With gravity and vacuum cleaner effect. See, okay? These are all the things which make the procedure faster. Otherwise, you will be unnecessary. See, in supine also they come like this. In prone also they come like this. See. Okay? See, everything is coming out. I have not used forceps. I am emptying the system. You got the point? So you don't miss any stones. Now ready for the breaking? Yeah, breaking please. See, all the flush is coming out. She is flushing nicely, very good. And too much flushing from below is also not good because pressure in the kidney may raise. Now no bleeding absolutely. So now you break properly. See, this is the focus. 1, 2, 3. Then superficially you should touch. Finished. Okay. Like this. Center of this stone you have to break. That is called bench breaking, I say. See here. Very big stone. So that's why what we have done. See, the mucosa may bleed. It is a upper calyx, so you should be careful. That's what I was telling. So you can close that. There is a small mucosal breach. That's why it is little bit of bleeding. Not much, but vision will get obscured. Flush. Forceps. Something is coming. Very small, see, you adjust, see it has come out. Okay. You should have patience because our sheath size is very small. So lot of seniors will increase the sheath size to bigger. Okay. Okay. Take it out. Okay. No torrential bleeding, no problem. No need to worry. Okay. Give me the. See, it is laser fiber, please.
Laser fiber.
Now laser fiber can make a designed cut. Laser fiber. Why laser fiber is taken away, ma? Why I have kept it here? See, is contaminating so much. My goodness. Why laser fiber should be here? I told. See. Now, why I have taken foot pedal to me?
Sir, 1 second.
What you did do? What is the difference between now and now? Fragmentation mode. Water, please. See, this piece has come out. Like that, you see, anyway this will take equal time whether you have made a fragment. See, this is called fragmentation to the desired level. Okay, see, can you see? Slowly you come out. Then if the suction is there, it will be really good, like say Shah suction. He is putting suction from outside. See, now the fragment is there. How to break it? Center you go and break it exactly in the, which is the right side or left side?
Right side.
This is the fragmentation mode. That's all. You go there. Okay? You take them out. You got the point? So ultimately people say it may take time, but bleeding will be less. So do you want this type of surgery or 30 French dilatation and fatapat remove in one piece in your relative? This type also, because you cannot say that 15 minutes time is waste. But if any bleeding happens,
Infundibulum is not allowing the scope properly. This smaller one and height.
no, this is not smaller one. This is 12 French. Scope is going. But I have not tried the sheath because it may tear the infundibulum. At this tearing the infundibulum is. Yes, that is a very valid point he is telling. What Ramakrishna sir is telling is, if you do even if you do 30 French dilatation, only one advantage is that fragment can be pulled. That is also dangerous. How can a large fragment you can pull right or left? Not getting full fragmentation here properly. As much pneumatic, it will not come. See, this is a big stone. You got the point? So what you need in big stone? In mini park? What you need? What you need? Patience, patience, patience. You can't expect a fast surgery with a small hole. You got the point? So you should have patient, come out safely. Patient can be discharged very fast. You got the point? Patient can be discharged very fast if you do mini pair. But if you do surgery very fast, patient discharge may get. I am trying to break, it is very hard. You got the point? Very hard stone. These are ideal cases for pneumatic lithotripsy. But pneumatic lithotripsy can cause mucosal injury. Laser unlikely because you don't perforate now with laser. Whereas pneumatic can hit like a just now you have seen a little bit of bleeding. It stopped. Every fragment is coming. Are you recording this?
Yes, sir.
So in prone PCNL also this will happen because pressure created by the water is so this is another method because it creates the negative pressure. Laser also creates negative pressure. You know that clearly? So you should have this patient. Why I have taken is, it will take time. What is there in this? Puncture is more important. This you practice in your private practice, no problem. It is only practice. Movements, you are already doing well. You have done pneumatic lithotripsy, you have done with the big stone. Any person who attempts RIRS because it is in the upper calyx is a futile attempt. As the experience increases, we are not attempting large stones for RIRS. I am doubtful whether it is going into pelvis somewhere.
Straight గా కూడా లేదు, medial గా ఉంది.
Yeah, straight ga kuda ledu. What we think in RIRS, upper calyx may not be always possible easily with the plexi. Upper calyx may not be always a beautiful calyx for RIRS. You got the point? Yeah, I am trying to make it pieces. It is taking time. No problem. What you need is patience. If the stone turns like this, it is better. We have still not much used the forceps. So if you don't have patience, circumcision will take how much time? 1 hour. Why you don't want to take time for 1 hour per stone in advanced endoscopic surgery? Huh? You have to take or no? You should take. Why I am moving to the normal side? Because I don't know what is back. Is it pelvis communication? If it is a closed calyx, I am enjoying. Closed calyx. Lot of people say fragmentation is not good with the thulium fiber laser. It is true for the hard stone. Unless you increase the laser energy to high level, it won't. Now it is time to move a little bit of the what is this? Little bit of the ampulla inside the mouth. Okay? So that now there is another method. You hold it, don't give to him. Now water will be better if the laser fiber is out. So that also you should not see how the fragments are coming. You record both screen as well as this.
Yes, sir.
See, it's cleaning. See, slowly I am rotating. Meanwhile, what happened? The infundibulum got dilated. All fragments are coming like this. All fragments are going down. Don't go down, Sridhar. All fragments you keep there. This is the classical mini PEG supracostal puncture. This 15 French starch is very small. If it is 22 French, slightly bigger fragments will come. But again, patience, patience, patience. I don't have patience, that's why I am saying that sentence. If you spend another how much time? Tell me. Maximum 10 minutes. What will happen in 10 minutes anesthesia in a young patient? Nothing will happen. So you should have patience. Will break pieces. Will break pieces. As the stone density becomes less, pieces will become faster. So don't worry that they will not break. Absolutely there is no bleeding. And everything is under your control. Hold it. Yeah. So now you go inside and drink. If you want, you can use the forceps. There is no harm. Okay. But forceps logistics in micro per car, poor. Poor. Why? Water flow decreases. Vision will decrease. You will struggle. So this is better. They will come out. They will come out. There is no need to worry. You need not worry. Everything will come out. Sister is doing good job. Gentle suction, gentle flushing from she is doing from below, and they are coming out nicely. As the stone, the volume becomes less, these fragments will come out more easier. Why? They will have space to move. Now can you do the popcorn technique now? Can we use popcorn so that they will become very fast powder? Let us see all the gadgets, all the modes we are using now, okay? What is the requirement for popcorn? Left, right?
Left side, sir.
Left. It is fragmentation. So large stone popcorn will not happen. Now everything is over. Where is this? Where is this? Last. So that's all. Now push this, come out once, come out two. How he is holding with suction, you see. What is this stone? See, rotation. Rotation like this. Rotation like this. Like this. Okay? Rotation like this. Okay? Okay? See how many stones are there. They are all coming down. This is the dependent part. So you have to lift the a little bit. Okay. Pass the guide wire from below. You go the page. If the guide wire comes here, it is better. You can put the stent properly.
ब्रेकिंग
Information is that we are at the edge of
ब्रेकिंग वायर आप लोग जिसको
okay. That's all. Next time we will use the sharp sheet so you might have done better with sheet. Okay, see here, helix, okay, it's a single stone, completely clear. You remove this, all this powder also. So, pass the guide wire if it comes very nice, because you need communication with the communication with the pelvis. That is the most difficult part now. What up? That is the most difficult part now. I think that's over, see that? See now, record there nicely. Okay, beautiful. Calyx is completely. This calyx is, the guide wire has come. Very good. Forceps, now I am using the forceps. Now over the guide wire, I will, where it has come, you see, where it has come, you see, where it has come, you see. This is medial calyx, which is first guide wire very see where it has come. See here. Have you ever thought that this will go like this? Okay, you should be careful. This is a very narrow infundibulum. See, can you see here? See now directly you give me you take out the ureteric catheter, not guide wire, ureteric catheter. Ideally you should take out the ureteric catheter. Stent please. No cutting stent. Correct, come on sister. Why are you cutting? You have to push with the. See, now you are directly going through the.
I'll keep guide wire in only, sir.
Guide wire and remove that. Why? If any problem arises, at least the guide wire will save me. Have you seen any small fragment in there? No. Why? Now you take out the ureteric catheter, please. Out. Water reduce a little bit. Guide wire also has come out. It should not come out like that. Okay. Now see. Now. Okay. Now only thing is we have this is the calyx. Okay. The guide wire has stayed in the guide wire. That's why guide wire inside. So take out this. Okay, I have to go now smartly into the ureter carefully without raising the flap. Take the forceps quick. Now you don't do anything. Guide wire has no role now. I will take out the stent and put it in the area where I have done the. It's not necessary. Actually, stent doesn't have any role in this. Stent. Why? Because you have not touched the of the. Why it is not holding? Take it out. Now give me it. So you have to hold properly. There is not an infundibular surgery, isn't it? You have done. It is not related to the infundibulum. See, coming or not? Not coming. There is an angle. Anna?
Yes.
There is some angle. The flap is raising there. Come. Anything is holding from below? No, no. Guide wire has come out. Water, please.
Water on.
Slow. Thing is. It is not coming yet. It has come. Okay. Now. Okay. Now it has turned into our calyx. Is it over? See now. Okay. That infundibulum should not get stenosed. Otherwise, what will happen? Entire calyx will get. Now that is enough. See now give me the contrast. Give the contrast. Very good. Hold it. Water stop.
Water off.
Contract please. See take out the hands. Contrast fast. See that's all. Okay. That is the picture. If you want to give more contrast, you give it. Or else you can put the unnecessarily. Why to waste? Give it for the naam ke vaste. You can put this and inject the contrast. You want to keep this? No. Supracostal, it is painful, isn't it? Couplets on. I want to inject contrast and see any pleura, any this thing is injured. See. See. Can you see nicely the track?
Yes, sir.
Nicely the track. No pleura, nothing. Clearly. That's all. Take picture also, no problem. That's all. The stent is up in the calyx. Now one stitch we will put here. This is microperk, little bigger incision, nothing will happen. Only thing is, you will take anyway one bite. There is no absolutely bleeding. This is above the 12th rib. This is the 12th rib, this is the 11th rib. Perfect supracostal puncture for demonstration. pleura if it is injured or not, if the pleura it does matter what. See once CM. Yeah, now exactly in that calyx we have the stent. So you take a bite, give me the sensory cane, one bite, that thing will happen. If you keep the nephrostomy, pain will be more. You got the point? See, sir? Now give me the sensory cane. Sensory cane not taken. Yeah. Inject one sensory cane, then turn the patient, and stent was also not necessary, but infundibulum was narrow and little bit of mucosa is irregularity there. So better to keep across, it will seal off. And 80% of the mucosa, if it is intact, nothing will happen. We have not done anything there. While only passing the scope, it was acute angulated. You got the point?
Yes, sir.
Give it adult patient, no need to dilute. All you need is, this will give lot of comfort for 4 to 6 hours to the patient. Immediate post-op, what he will complain? Only pain. He doesn't know what mini perk, micro perk you have done. Liberally you inject everything. That's all. He will have pain free. Now other pain which will have will be ureteric catheter pain. Ureteric catheter there, na? That pain as if I want to pass urine, I want to pass urine, he will get. Thank you. So the most important point is in supracostal puncture is in prone PCNL, try to go lateral, try to go superficial, direct, one go it go. 3 problems we faced here. One is guide wire got little broken. Second is the direction of the dilatation was little different. I have to take over. After that, infundibulum was medial and the calyx was medial. It was anterior. You have done with laser half. You have done 10% with pneumatic lithotripsy. I have taken pneumatic lithotripsy. I tried to break. Again at the end I have taken laser. Some more fragments are all came out. Mucosa is intact. Then because the guide wire has come, we could identify the infundibulum. Otherwise it might have been difficult. When we are going obliquely, little bit mucosa got disturbed. So better to keep the guide wire in the medial calyx where you have operated and take out the stent after 2 weeks. Then absolute result will be there to the patient. At the end you injected the contrast. While coming out you withdraw the nephrostomy so that colonic injury and pleural injury. Visceral organ injury may not be seen in this case. It is not possible. But grossly it is not there because you are lateral to the mid scapular line. Good. Thank you. Dear audience, there are certain points I wanted to mention. This is totally unedited video. See, puncture is done by the junior. In one go, the urine has come. But what the juniors do small mistake is, after going into the rectus sheath, they will change the direction in an acute angle. So don't think that by puncture and passing a guide wire, you can dilate easily. So in this case, he punctured initially with 40 degree and later with 20 degree. At the rectus sheath level he went like this and then he came horizontal. That memory if you don't have, sometimes this guide wire will be of no use. People are suggesting that facial dilator, cobra dilator, back of the Alken rod. I only have dilatation today. I have also have 15-17 years of experience. Purposefully I have chosen this case because if everything goes well from top to bottom in 10 minutes, then what the junior will learn. So I thought most of the cases, my cases will be recorded. I thought when I was using the dilator which is from the Starge steel rod, 90% of the times I get good dilatation. It is perfect for rectus sheath, it perfectly goes. Today what happened? When we are putting the dilator, at one level it was kinking, 10-15 degrees. So I tried to withdraw the guide wire, thermo got outer coat removed. That happens 1 in 50 or 1 in 100 cases. Thermo quality is a problem and acute kink is a problem. Your Alken dilator is a problem, everything is a problem. But problem is problem. So what I did, it is very difficult if the guide wire damaged and kinked. Either you have to take it out and straight and then pass a bigger one. I tried that. Sometimes we remove the guide wire. What is there? You can puncture again straight direction. So if the puncture is not very straight, dilatation becomes difficult. That's why purposely. Lot of people think, why so much time? We can directly go with the facial dilator and then direct one step. Yes, it happens in 90% of the times, but sometimes it may not happen. The second point is, once the bigger dilator is kept mini par, that is 15 French, it went and I kept for some time and then I did once again. So establishing the tract is very important, not only the puncture. And we have dilated only the lateral calyx. After that we searched for the medial calyx. Directly puncturing the medial calyx in this case is not acceptable. See, one time when bleeding happens, you will sweat. Take all the precautions that in supracostal puncture, because the bleeding chances are more, try to be peripheral. So we were peripheral. So we went bigger sheath. We went with a small microperc. Why? Because mini perc 15 French, if you are to go with 12 French, guide wire becomes little a problem. If you remove the guide wire and after going inside, if you are not there in the calyx, it is more headache. So don't take chance. Either you dilate a little bigger, go with proper guide wire and scope, then only you remove the guide wire. Otherwise the purpose of the guide is gone. So I went with microperc. I have seen the calyx. Little microperc is a very small scope. Everybody thinks blood was there. In PCNL first 1 or 2 clots will be there. No need to worry for the juniors. You spend first 3 to 5 minutes in the calyx. You suck out everything. You spend, if the mucosa is seen, if the vision is there, no need to worry spending 2-3 minutes of time. Sometimes single just stone you pick up and take it out, it will come in 10 minutes. In this case it is not like that. Infundibulum of the medial calyx is small, admitting only 12 French nephroscope. Your pieces cannot be taken big and it may torn. It may torn. Upper calyceal supracostal puncture is not only the pleura. If you puncture the pleura, nothing will happen. What will happen next day? You can put the tube by you or chest physician. Patient will not die. But if you tear the infundibulum medially, anteriorly, torrential bleeding can occur on the table. You can't do anything. Before shifting the patient, it can die. Large stone fragment, if you try to pull out, the piece lateral side can tear the mucosa. It's a confluent 3 calyces. One is medial, one is lateral, and one to the pelvis, long infundibulum. It's bifid system or long infundibulum, nobody can say. This is the second point. Third point is, while we are searching, never search going deep always. Come back also. Sometimes you might have gone medially. It's a large lateral calyx, safe, no problem, no bleeding. Clot was removed. Once you came more back, carefully, slowly rotating the ampulla sheath, not out of the system. Then I have seen below stone. Once you see the stone, confidence level will increase. Then reassess the system. Where is the calyx you punctured? Where is the infundibulum? Where is the stone in the medial calyx? And you orient yourself towards that stone perfectly. This is the third point. And after that, what we tried, stone is sprouting through the infundibulum, which is very big stone inside. Small this thing. Big and small stone again depends on the micro, mini, normal pair, 30 French. If 30 French is there, forcefully entire stone will not come out in this case. You have to break with pneumatic lithotripter. Probably 10 minutes before you might have taken out big pieces, but those big pieces is a concern, as I told. So once you see the stone, stabilize everything. The junior was playing nice painting. You get tempted to do fast. How can you do fast? What is the maximum energy you can go in laser? 25 watts in this. Even 25 watts does not break like a pneumatic lithotripter. Only in the edge they will pick a bigger micro fragments. But you can't break like a pneumatic lithotripter 4-5 pieces stone. That is laser. But surgery looks beautiful. It takes time. You should spend, if I have done this with laser, same time it might have taken. In between I have purposely taken the pneumatic lithotripter. Pneumatic lithotripter is useful when the large access sheath is there, when a large infundibulum is there, when stone is fixed, it will break into pieces. When stone is moving, pneumatic lithotripter laser is better. Here, large is not the criteria. Infundibulum small is the criteria. So play safe. So what we have done, half of the stone we have done nicely. After that you got the space. The junior was creating little bit of space and going. That is good. Then at a time acutely dilating into the infundibular calyx. Now once you go into the calyx, once you got space, stone is moving, I have taken pneumatic lithotripter. What happened in pneumatic lithotripter? You will hit the stone in a impacted stone, very small calyx. Sometime it will hit and may perforate also. Laser, lot of people think that laser will perforate. You can't push the laser fiber because it will be under vision. But when you are doing pneumatic lithotripter, sometimes in a fixed stone, it will go and make a small hole. That is also dangerous. Pneumatic lithotripter usually in the ureter, no problem. But in the kidney, if you don't see and perforate, that can cause bleeding. Then in that case, you have to wait for some time. It happens small mucosa, just for 2 minutes of time it settled. After that, laser for small pieces, it came out. There is no problem. The last point, fourth point which I was, if you have an access from below ureteric catheter to pass a guide wire, it is better. Always have an access, don't remove. Guide wire has come into the upper calyx through the narrow opening of the infundibulum of the 3 confluent upper calyces, which if you damage is equal to partial nephrectomy and unnecessarily inviting the problem. So small nephroscope negotiated, went to the long ureter, ureteric catheter seen, single fragment powder has not gone. That means it is a very acute communication with, normally powder at least will go into the dependent calyx or dependent pelvis. It has not gone. But the guide wire is there, the stent is passed over the guide wire or from above, and once to bring it out, it took 2-3 times attempt because it was not holding and angle is acute. So you have to bring slowly. Better if you are putting stent, keep it in the upper calyx. Why to keep in the pelvis? There is a single stone not there. There is no inflammation below the infundibulum. If at all you have done anything in the infundibulum which is communicating to the lateral calyx, not communicating with the pelvis. At the end you inject contrast always if you have doubt, otherwise no need. While coming out recently I am practicing injecting contrast so that you can see the track. This is particularly useful for colon, not for other things. Don't expect liver perforation will be seen. Don't expect the pleura will be filled nicely with the contrast. It will not be seen. Only colon, even if you inject 10 ml, 5 ml, the outline of the colon will be seen if you observe carefully. But supracostal puncture on the left side or right side where colon was not there in the region of the puncture, so that will never arise. So in this case, injecting contrast and coming out to see the colon does not arise. Overall, time taken was around 48 minutes and the procedure is done slowly. Guide wire has kinked, it readjusted and entered successfully. There was no bleeding at the end of the surgery. Patient post-operatively was discharged on post-op day 1. Absolutely no problem. Next day he was discharged and the stent will be removed after 2 weeks. Chances of fragments in the pelvis getting in the ureter struck is very, 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 very less. That is what conclusion. Now coming to the Harshavardhan. Harshavardhan is a good surgeon. He might have thought that it might have done with Cobra dilator. It is his favorite, blue dilator, blue neem. That is good. In this case, I have not used this. I thought steel rod is better. These are all the exact what happens in theatre. Don't think that everybody every day will do 100% like this and take out the stone and 2 fragments will come out. No. You should use absolute basic principle. That's why I was, while teaching to the fellow, I was guiding all this. Next thing is, good evening, sir. Dr. Shankar Gundal, can we dilate tract till fascia with artery forceps? I strongly advise not to do this because it is blind. By the side of the artery you can open like this, but there is no guarantee that it will exactly go into the by the side of the guide wire and open. It won't usually open like that. So you should be careful. That is one thing. Next, step negotiation in PCNL tract is crucial point by Harshavardhan. We'll use Cobra catheter as a guide system, help in such situations. So whenever there is kink, it is a very valid point. If you have somebody has punctured like this and then this, to do dilatation, the dilator also should have flexibility. So Cobra dilator is very useful in such cases for initial dilation. After that you pass this. But why I have not passed Cobra dilator? Because the kink, my the puncture and dilatation I am expecting up to 12 French only. Cobra dilator is very useful if you are expecting up to 20 French because single step dilatation can be done. Over the cobra guide wire, you cannot pass the ultra mini perk sheath. You cannot pass. So then it is difficult. So that's why I used a bigger dilator and then passed with my experience. Next, coming to the Omar Acosta. Good morning, Simsima. Why don't you use alkan axis to avoid with kink? That is correct. First time, if you are doing multiple dilatations, alkan is better. But in this case, I was not expecting multiple dilatations, only one or two. First one only got difficult. So alkan also will cause difficult. So alkan rod, anything will difficult except cobra as mentioned by Ashavardhan. Cobra can pass in a kinked puncture. Now, excellent demonstration, difficult case. Not a very difficult case, but some difficulties are there. It is not difficult case. Somebody might have done very fast also. Some difficulties I have encountered. That's why it is already done case. Purposefully I have kept as a full line. Next, what should be the zone size limit for single stage RIRS? Lot of people will ask, any size is okay if you have a very good access to the with flexible scope, easily if the stone is seen, easily if the powder is made, easily the ureter getting the water coming out of the ureter easily, then up to 2 cm, 2.5 centimeters, no problem. Especially with thulium fiber laser, it goes fast. But you should know what is the easy case. Easy case is when the ureter is fully dilated. Easy case is when water is coming out easily. Easy case is when flexible scope is not difficultly bent. Easy case is when all parts of the scope is seen with the scope nicely. Then you can spend. But even then more than 1 hour spending, I personally don't advise because it increases the pressure in the kidney. Kidney becomes boggy. If you do laparoscopy after RIRS, you will see lot of the water outside. That is the one question. Now Sandeep Vadigiri, sir, while giving apnea, anesthetist complains of desaturation. Don't give apnea. See, deep inspiration only for puncture you have to give apnea. Once the needle and the guide wire is inside, some amount of fixity of the kidney will come. It won't move like left and right, up and down like this. So first dilator, you can ask him little bit. After that, there is no anesthesia role in this. First puncture, deep inspiration, get it little low. One step you puncture, pass the guide wire, and then in this case guide wire did not go into the ureter, so we should be skeptical because that round better to keep 4-5 folds, because if any problem like in this case the guide wire kink, you can withdraw and do it. If you keep only small, if you withdraw it will come out. So keep 4-5 rounds. If the calyx guide wire is coiling in calyx, it is not a good proceeding. If the guide wire goes to the desired calyx position, good. If the guide wire goes into ureter, good. If the guide wire coils in the calyx where there is no stone, very dangerous if you do wrong dilatation, if you go inside and cannot communicate. So don't be happy when the guide wire coils in the calyx 4-5 times. You can only get an access to the mucosal lined cavity, but doesn't give guarantee that you will go. That's why I did ultra mini perk, mini perk with ultra mini perk with 7.5 nephroscope. After seeing mucosa, I am comfortable. That is another point. Next, sir, Sandeep again, when will be the risk of AV fistula and aneurysm increases post-op PCNL bleeding if there is no facility for interventional radiologist to put coil for how to manage? See, in this case we have done dilatation up to 15 French only. Under vision we have seen. While at the end of this surgery absolutely no bleeding. In such cases chances of aneurysm are less, but still can happen. You should be in the periphery of the calyx, lateral, in inferior calyx and superior calyx. In case of middle calyx, anterior posterior, again in the anterior posterior, lateral. In the anterior, the lateral means cup of the calyx. So here the question you asked is angio. See, remember, this is a very important question, practical point I am telling. Any important center where angio facility is not available, have a connection with good friend. In the city where you have nearest city, very good friend of you should take care that case like his case. For example, if you send to Hyderabad, I have two types of facilities. One is 30,000 I can do angio with a better place where angio is available. that person radiologist my close friend. Midnight also he will come and do it. Corporate it will cost around 80-85,000. Everything is important. A friend who can help you in the midnight to get it done, you should not worry. You only give the money 30,000 and send. Let the patient be all right. Patient safety important as early as possible. Once you decided that angio has to be done, bleeding is happening, send. Angio is nothing. In fact, the place where I do, if only angio is done, we charge only 5,000, 6,000. If angio intervention is done, it is 30,000. Can you imagine 30,000? Can you get angioembolization? If poor patient is there, if rich patient is there, 40, 45,000, 50,000. In corporate, it will cost around 1 lakh. So be careful in sending the case where not only angio facility, but also person who is going to take care of your patient. That is important. Postperineal bleed, risk of nephrectomy. To pray the God that should never come. But you should be able to do it. But I have not seen, I don't have experience. 24 hours, 24 French versus 16 French sheath in last shift. In terms of the vision, you said 24 French over 16 French. See, if the infundibulum was, if the stone was directly in my calyx, if the sheath is little, bigger, you can put. I might have finished case fast. But the problem here is lateral calyx I went. After that I came into the medial calyx. So infundibulum does not allow more than 15 French. Anytime large French is better. Put 30 French and remove stone in one go. But for that you need an access directly safely. 30 French bleeds, 24 French bleeds, 22, 18 are ideal. If you are in a very tough environment like today, it is 15 is better, and take additional 20-30 minutes of time. I do understand any senior who has done say that, oh, it has taken time here, I might have removed fast. Fine, no problem. It is his experience. But I felt that when I am teaching junior, you should not be in hurry to do that that way. Okay, right. Thank you for patient listening. And any supracostal puncture is no different from the infracostal puncture. Once you used to do 3-4 cases, it is not that difficult. Concept is supracostal puncture, the bleeding chances are more, so stay lateral to the calyx, access to the calyx with minimal dilatation. Once you are comfortable, you can increase the dilatation. Thank you very much for patient listening. We will keep this type of videos. In the initial process I am doing, so that the other seniors are ready with the cell phone recorded unedited videos. I was a period of time urethroplasty and all these things. But this much time we cannot put. We will reduce the time in the future. This today puncture only I might have shown, but so many